Hello and good evening, everyone. Good evening, Prof. We are going to commence the first presentation on the general surgery weekly presentation, where Dr. Sakina Abimuku will be taking metabolic response to trauma. It is a very important topic in practice as well as in your exams as residents. So I'll encourage all the residents to pay careful attention and jot down their questions and comments after the presentation. We are going to entertain a question and answer session. And we are very honored to have Professor Yahweh amongst us, the former president of the West African College of Surgeons. And thank you very much, Prof, for sparing your time to educate us. Prof Yahweh is the trainer of our trainers. So you are all fortunate to be on the same platform with him to be receiving such a presentation. So thank you very much, sir. And please, good evening, sir. You are welcome, sir. And please, if your mics are you should remain muted so that you don't interfere with the presentations. During the question and answer session, you will have an opportunity to ask questions. So thank you very much, everyone. We are going to give Dr. Sakina Abimuku 30 minutes to have the presentation. Thank you very much. So Dr. Sakina, you can start.
Okay, good evening. Good evening, Professor Yahweh. Good evening, my consultants, senior registrar, residents, and house officers. My name is Dr. Abimiku. I'm a resident in general surgery. I'll be making a presentation on metabolic response to trauma this evening. This is my outline for the presentation. From introduction, statements of surgical importance, activators of metabolic response, mediators of metabolic response to trauma, response to injury, factors that influence metabolic response to injury, attenuating metabolic response, conclusions, and my references. Following injury, which can either be accidental or deliberate, a characteristic series of changes occur both locally at the site of injury and within the body generally. These changes are important because they intend to restore the body to its pre-injury condition. Although this metabolic response are beneficial to the individual, a major response can actually cause organ damage distant to the injured site itself. Before I go further, I would like to define some terms. Homeostasis is like the basis of normal physiology, and this is defined as maintenance of nearly constant condition in the internal environment of the body by coordinated physiological processes. Metabolic response to trauma can also be defined as body's damage control system intended to maintain homeostasis at cellular as well as systemic level. Why is this topic important? This topic is important to us surgeons because understanding the complex pathways that regulate local and systemic response to trauma is necessary in order to develop strategic interventions that will minimize metabolic response to trauma during overwhelming sepsis and severe injury. It's important also because it helps to shorten recovery time and improve outcome. Since surgeons are potential source of trauma in major operative interventions that we do every day, it is therefore important that the surgeon must understand the body's response to trauma so as to prepare the patient adequately preoperatively, intraoperatively, and postoperatively. When trauma occurs, there are certain factors that helps to initiate this cascade of metabolic response. These factors include pain, hypovolemia, inflammatory tissue, hypoxia, and hypothermia. Pain is a potent stimulant of the hypothalamus to release gonadotropin-releasing hormone. This hormone acts on the anterior pituitary to cause release of ACTH. ACTH acts on the adrenal cortex in the zona vasculata. It causes release of cortisol and aldosterone from the adrenal. And the effect is that these two hormones will cause tachycardia and increase intravascular volume. All this in order to conserve blood volume. And cortisol also helps to activate the immune system. So apart from pain, fear and anxiety also activates metabolic response through the hypothalamus. Another important factor is hypovolemia. In a setting of hypotension and hemorrhage, the baroreceptors located in the aorta and the carotid body can actually get activated. And once they get activated, they send out they increase sympathetic outflow via non-adrenaline, which acts on the heart to increase cardiac contractility, heart rates, in order to improve cardiac output. Another factor is inflammatory reactions that arises from damaged tissues. They release chemicals that helps to activate immune cells. These immune cells include macrophages, monocytes, lymphocytes, which produces cytokines. We are still going to talk about each of these cytokines and their function later in the presentation. So once there's trauma and the metabolic response has been activated, there are actually three systems that come into play to provide support. We have the neuroendocrine, sympathetic response, and the immune response. Neuroendocrine response pathway, the classical neuroendocrine pathway of stress response consists of the afferent nociceptive neurons, the spinal cord, the thalamus, hypothalamus, and the pituitary gland. I will explain further with a diagram as I move on. And also when the hypothalamus is stimulated, it also stimulates the sympathetic system to release adrenaline or non-adrenaline. This is the fight or flight hormone. It acts on the cardiovascular, the visceral and metabolic system. It diverts blood from the skin and visceral organs to more important organs such as the brain, the heart, the kidneys when the body is faced with trauma. It also acts on the heart where the alpha and beta receptors increase heart rate, increase myocardial contractility, all this in order to increase the blood volume and conserve intravascular volume. Via the beta-2 receptors, it also causes bronchodilation in order to increase the oxygen level. It reduces GIT motility in order to divert all that blood and energy to vital organs like the brain. And also, adrenaline, when the sympathetic nervous system is stimulated, it also releases glucagon, which helps in glycogenolysis in order to provide glucose, which is an important substrate. This is the diagram I'm talking about, showing us the neuroendocrine response and the sympathetic response. So starting from here, when there's an injury, the afferent nociceptive pathway is stimulated, then it travels up through the spinal cord to the brain. In the brain, the hypothalamus is stimulated to produce gonadotropin-releasing hormone, which stimulates the anterior pituitary to release ACTH. Also, growth hormone is released in the anterior pituitary, and then it causes breakdown of fats in order to provide substrate for glucose production. Also, this ACTH also acts on the adrenal glands to produce adrenaline and cortisol, which helps in hepatic gluconeogenesis. And also, through the hypothalamus, the sympathetic nervous system can also be stimulated. It leads to release of adrenaline and glucagon from the pancreas. So moving on, the purpose of neuroendocrine changes. These changes are important because it provides essential substrate for survival. So for survival, like you can see here, it provides glucose for survival here. It also postpones anabolism. It optimizes the host defense system too. These changes may be helpful in the short term, but may be harmful in the long term, especially to the severely injured patients who would otherwise not have survived without medical intervention. Another mediator of metabolic response is the immune system. Once there's trauma, the immune system, there's an interaction between the innate immune system, principally made up by the macrophages, and the adaptive immune system, made up by the T cells and the B cells, in order to generate metabolic response to injury. Their responses are manifested as fever, leukocytosis, altered respiration, and increased heart rates. Also, this immune response is mediated by cytokines. The cytokines, we have two types, the pro-inflammatory cytokines and the anti-inflammatory. For the pro-inflammatory cytokines, these are the ones that support inflammation. This includes tumor necrosis factor, interleukin-1, interleukin-6, and interleukin-8. They are all produced from the macrophages and the monocytes. So they are pro-inflammatory, and then their function is to activate leukocytes. They also initiate muscle catabolism. Interleukin-1 and tumor necrosis factor activate the thermostat center in the hypothalamus, and they cause fever. Then we also have the anti-inflammatory cytokines. This includes interleukin-4 and interleukin-10, which both inhibits immune functions. So they are in humans. The response to injury is divided into two phases: the ebb phase and the flow phase. The flow phase is further divided into catabolic and anabolic phase. The ebb phase, also known as the shutdown phase, it begins at the time of injury and it lasts for approximately 24 to 48 hours. In the ebb phase, the body is trying to actually conserve all it can it's trying to shut down and conserve all it can. And it is characterized by hypovolemia, hyperglycemia, decreased basal metabolic rates, reduced cardiac output, and hypotonia. This ebb phase is regulated by hormones such as catecholamine, cortisol, and aldosterone. Like I've explained earlier, the physiological role of the ebb phase is to conserve both circulating volume and energy stored for recovery and repair. Although this ebb phase cannot be abolished completely, but it can be attenuated by adequate resuscitation. So following adequate resuscitation, the ebb phase actually evolves to the flow phase. And this flow phase is a hypermetabolic phase, which is characterized by mobilization of body energy stores for recovery, repair, and replacement of lost or damaged tissue. Is divided into two, the catabolic and the anabolic phase. The catabolic phase has a duration of 3 to 10 days, and the main role is for mobilization of energy stores in order for recovery and repair to take place. This particular phase is regulated by the counter-regulatory hormone, which is the glucagon, cortisol, catecholamine, cytokines, and insulin. And it's characterized by increase in metabolic rates. There's increase in temperature arising from the cytokines. There's also increase in oxygen consumption. Also, there's negative nitrogen balance, which I'm going to talk about as I go further. There's hepatic acute phase response. After the catabolic phase, we have the anabolic phase, which lasts from 10 to 60 days. And the main role is for replacement of lost tissues and is associated with positive nitrogen balance. So when there's an injury, the body tries to respond in several ways. The first one is retention of water and sodium. The body tries to do this in order to protect intravascular and extravascular volume. And this is mediated by two hormones, the ADH and aldosterone. ADH is released from the posterior pituitary, and its release is stimulated by osmotic factors such as increase in plasma osmolarity. When the baroreceptors are activated, stretch receptors, pain, and drugs. So it acts on the distal collecting ducts in the kidney, where it facilitates absorption of water. Aldosterone is released from the adrenal, and its release is stimulated by renin-angiotensin system, decreased sodium, where it acts on the distal convoluted tubules. it helps in absorption of sodium. So these two hormones together act in absorption of water and sodium in order to conserve the intravascular volume. Initially, retention of water and sodium was thought to be obligatory. However, it has also been shown that this response can actually be abolished Preoperative intake of water and clear fluid 2 hours before anesthesia is safe and is associated with increased post-operative well-being, and so attenuation of this retention of sodium and water. That's for a patient going for an elective procedure. Then accidental trauma, even though you can't abolish it completely, it can actually be minimized by adequate correction of hypovolemia. Another response also is increased renal excretion of potassium, which is maximal on the first day, and then it returns to normal by the third day. Another response again is altered protein metabolism and nitrogen balance. In major traumas and sepsis, in major trauma or sepsis, protein turnover, catabolism, and synthesis are increased, but catabolism is more than the protein synthesis. This results in negative nitrogen balance. And most of the nitrogen lost is lost in the urine in form of urea, and it arises from the skeletal muscle. So the skeletal muscle undergoes proteolysis, which is caused by interleukin-1 and tumor necrotic factor, in order to release amino acid. So prolonged protein catabolism leads to loss of body protein, pulmonary and cardiovascular failure. It can also cause impaired function and wound healing. Negative nitrogen balance has been thought to be obligatory, but it has been shown that by simultaneously infusing amino acids such as glutamine and increasing protein synthesis, it can be attenuated in moderate operative injury, which will actually be beneficial to the patient. Also, use of epidural anesthesia and analgesic also helps by blocking the afferent neural stimuli. Thereby, it abolishes release of catecholamines and cortisol, thereby reducing inflammatory response. Also, laparoscopic surgery is associated with minimal tissue damage. So that also helps to reduce inflammatory response. Then immediate post-operative enteral feeding helps to improve positive nitrogen balance. Another response seen is hypermetabolism. It has also been shown that the resting energy expenditure is increased after trauma. It increases by at least 10%. So resting energy expenditure simply means the calories needed to maintain basic body systems and body temperature at rest for an individual. So this resting energy expenditure increases by 10 to 25% in major fracture, 50 to 80% in sepsis, then as high as 40 to 100% in severe burns. So when there's trauma, the glycogen reserve in the liver is just enough to provide energy for 12 to 20 hours after trauma. Thereafter, most of the energy is from combustion of triglycerides and protein. That's if exogenous carbohydrate is not provided. So this is just a diagram showing us the sources of energy in trauma and sepsis. So starting from here, this is the liver glycogen. Under the influence of glucagon and catecholamine, adrenaline is broken down to provide glucose for the organism, which is used by the brain, nerves, white blood cell, red blood cell, and other tissues in the body. When this liver glycogen store is depleted, the body tries to look for other sources. And that's where the hypermetabolism comes in. It tries to look for other sources of energy. So starting from here, triglycerides located in the adipose tissue under the influence of glucagon, growth hormone, cortisol, and catecholamines is broken down to produce glycerol and fatty acid. This glycerol then is used for gluconeogenesis in order to produce glucose. Also, proteins located mostly in the skeletal muscle are also broken down to produce amino acid and amino acid, which enters the pathway to produce glucose for the organism. So there's also due to this hypermetabolism, there's weight loss with resulting fatigue seen after a major injury, and this is as a result of lipolysis, like I've explained, increased protein catabolism and diminish food intake. There's also insulin resistance. So this can actually be abolished by preoperative overnight infusion with high dose glucose or oral carbohydrate drink taken 2 hours before anesthesia can actually reduce response and insulin resistance. Another response seen is changes in plasma proteins. Acute phase proteins are plasma proteins whose levels rise by at least 25% following trauma and sepsis. They are divided into two. We have the positive and negative acute phase proteins. The positive acute phase proteins help in defense of the patient. So this is a slide showing us the positive and acute phase protein. So starting from the C-reactive protein, C-reactive protein helps in activation of complement. It opsonizes microorganisms for phagocytosis by the white blood cell, so thereby reducing inflammation and infection. So its level is increased when there is trauma. Haptoglobins helps in transportation of hemoglobin. Ceruloplastin helps in transportation of copper, which is also an antioxidant and is beneficial when there is injury. So the levels are also increased. Factor 8, von Willebrand factor, and fibrinogen all help in coagulation of capillaries that are injured in trauma and inflammation, thereby decreasing blood loss. But however, if this effect is allowed to go on for a long time, it can lead to development of DVT when the coagulation inhibitors are actually depleted. So that's why you don't want the response to be for a prolonged time. You try to attenuate it. Then the negative acute phase protein includes albumin and transferrin. Another response is immunosuppression and increased susceptibility to infection. A traumatized patient actually has immunosuppression from many factors, but mainly due to suppression of humoral and cell-mediated response. Abnormalities are seen in macrophages, dendritic cells, and polymorphonuclear cells when there is trauma. They tend not to function well. So some causes of post-traumatic immunosuppression include stress hormone, such as catecholamines and glucocorticoids that are released in large amounts when there is injury. This impairs with T lymphocyte function. It also impairs B lymphocyte function. It impairs production of antibodies and immunoglobulins. Prostaglandin E2 is a potent immunosuppressant which interferes with T lymphocyte and B lymphocyte. Then preoperative blood transfusion actually worsens immunosuppression and sepsis. Yes, if a patient is giving blood yes, it worsens immunosuppression and sepsis. Then gut integrity also causes post-traumatic immunosuppression because of decreased blood supply to the gut when there is trauma. This leads to translocation of bacteria into the blood, thereby causing sepsis and more infection for the patient. Then another response is the endocrine response, which I've discussed earlier. So hormones such as cortisol, aldosterone, adrenaline, which are released from the adrenals, they are also increased when there is trauma because they are all beneficial to the patient. The other hormones from the pituitary gland includes ADH, ACTH, beta endorphin, and growth hormones. Then some other hormones remain unchanged even when there is trauma. This includes thyroid hormone, thyroid stimulating hormone, luteinizing hormone, and follicle stimulating hormone. What are the factors that influence metabolic response? The nature and severity of injury influence the degree of response. So the greater the severity of the injury, the more the response. The highest response is seen in severe burns. Once the burns is more than 40%, it actually evokes a lot of inflammatory reaction, followed by sepsis and then major fracture. Nutritional status of the patient too. Well-nourished patients are more likely to have greater negative nitrogen balance compared to patients that are not that have a low nutritional status. And also metabolic response is seen in younger patients, is seen in younger adults, is seen more in younger adults, is seen more in males compared to the older older patients, and neonates or females. So how do we attenuate this metabolic response? Metabolic response to trauma is not obligate, but can be abolished or at least minimized. The key is adequate resuscitation in accidental injuries. Then for patients going for elective procedures, pre-operative, perioperative, and post-op management are important in order to control this response. So for accidental injury, resuscitation is important. This includes fluid and electrolyte replacement. This will help to abolish the water and sodium retention. Adequate analgesia will help to decrease. It will help not to activate the pain pathway. The cardiovascular support by inotropes, prophylactic antibiotics should also be given in order to prevent infection. Adequate debridement of septic foci, timely surgery for complications. For conditions such as peritonitis, sepsis, surgery should be done on time so as to minimize the degree of response. Nutritional support is also important. It helps to minimize this negative nitrogen balance. It prevents weight loss, and it also prevents immune system dysfunction. Then early mobilization. So for a patient going for an elective procedure, pre-operative measures include optimizing patient by correcting anemia and electrolyte derangement, treating infection, controlling diabetes and hypertension, cessation of smoking and alcohol consumption. Also, avoid excessive fasting, avoid prolonged inactivity prior to surgery. Then perioperative measures include appropriate choice of anesthesia. Like I've mentioned earlier, epidural anesthesia is actually preferred because it helps to abolish the pain pathway, thereby it abolishes the release of catecholamines, cortisols, and reduces inflammatory response. Minimal access surgeries, laparoscopic surgeries are better because they have minimal tissue damage. Aseptic techniques, meticulous handling of tissues, and blood conserving techniques. Post-operatively, adequate analgesia should be given. Early enteral feeding helps to maintain a positive nitrogen balance. Early mobilization, prevention of post-operative infection, and then reduce hospital stay in such patients. In conclusion, the body's response to injury is a complex phenomenon involving all the body systems with the goal of maintaining homeostasis. But some of the mechanisms in the long term become injurious to the victim. Careful targeted modification of metabolic response to initial injury may be the key to preventing death in the patient. Thank you. These are my references.
Thank you very much, Dr. Sakina, for this wonderful presentation, and thank you for keeping to time. And this being a very complex topic, I would like to briefly summarize the presentation in the next 5 minutes. Then we will now entertain a question and answer session. Metabolic response to trauma, we should understand is response following trauma or surgery by an organism in order to restore a normal homeostasis or to return an organism to a pre-injury state. So the entire essence of the metabolic response to trauma is to aid an organism restore a pre-injury state. And there are some this response, you should know they can be exaggerated. The response by the organism can be exaggerated, and this exaggerated response could be detrimental to that organism. So the aim of the attending surgeon is to understand the exaggerated response and to attenuate them in order to prevent the harmful effects of the responses to that trauma. And there are some certain factors that activate this response. The factors that will activate the response following trauma or surgery will include pain, hypovolemia, from blood loss, hypothermia, infection. So after exposure to trauma, there are some certain factors that will activate the response. Then after activation, there are mechanisms through which the organism responds. And these mechanisms, she explained, the neuroendocrine. And the neuroendocrine is achieved through the hypothalamus-pituitary adrenal axis to secrete ACTH and other hormones. It is also mediated through the sympathetic nervous system in order to release adrenaline or noradrenaline. This is also mediated via the immune system. And the immune system achieves this via acute phase reactions. Acute phase reactions release cytokines as well as acute phase proteins. Okay, so after these mechanisms is initiated, it goes through phases. It goes through phases which are overlapping. The phases which the metabolic response to trauma undergoes include the ebb phase and the flow phase. The aim of the ebb phase is to conserve energy. It's a state of shock. And the entire aim is to conserve energy in order to save for the next phase. And the next phase is the flow phase is further categorized into the catabolic phase and the anabolic phase. Now, the catabolic phase helps in mobilizing resources. It's for mobilization of resources, while the anabolic phase is to use the resources that is mobilized to rebuild or repair the patient. Now, these are the phases that this response passes through. Now, there are some certain responses that are recognized. And these responses, she mentioned several of them, like retention of water and sodium, increase renal secretion of potassium, increase protein turnover, hypermetabolism, increase acute phase protein release, immunosuppression, and susceptibility to infection, then endocrine response, which she mentioned. And there are some certain factors that will affect how an organism responds to trauma. These factors, the most important one is the degree or extent of the injury. The more the degree, the higher the response, which she cited burns as one of the severest injury that triggers more response. And finally, she talked about the factors, how to attenuate, which is the major aim of you understanding this topic, how you attenuate these responses in order not to be detrimental to the body. The most important attenuation is an adequate preoperative optimization of a patient. When you adequately optimize a patient preoperatively, the response is controlled. There are some intraoperative measures she mentioned, like anesthesia, proper tissue handling, and also you shouldn't forget post-operative management of the patient. So this is a summary of the presentation that was delivered by Dr. Sakina. So now we will move to the next phase of this presentation, which is question and answer session. So, so you can unmute yourself, and if you have any question, comment, or contribution, please, you can go ahead. Thank you very much. And thank you, Prof, for your patience. Yes, any questions, please? Please, you can unmute your mics and ask your question.
Hello, good evening, Prof. Good evening, consultant, senior registrar, and registrar. Dr. Sakina, thank you for the presentation. Please, I want to ask, you said pre-operative transfusion will lead to cause infection. So in that case, what can we do? And again, a patient with a low PCB that must go for an emergency surgery, what can we do with respect to that? Thank you.
Dr. Sakina?
Okay, thank you for your question. Okay, actually, blood transfusion, perioperative blood transfusion actually worsen immunosuppression and increases risk of sepsis because this depresses the T lymphocytes and natural killer cell function for 30 days. So I think if you need to transfuse the patient, you can also use other measures to prevent infection by giving antibiotics, adequate debridement if there is need to do that. That's all I can say about that. Thank you.
Thank you.
Yes, any other question?
Yeah. Good evening.
Yes, good evening. Introduce yourself.
Yeah. Okay, Dr. Sakina, good evening, Prof. Good consultants. Thank you so much for the presentation, Dr. Sakina. Some contributions to make. The first part, I want to look at in the response. I didn't hear much about though you mentioned that there is a gut transplantation of organisms, but then there's an important thing that you need to mention, which is what happened to the GIT during this response, because we know that blood is shunted, as you mentioned, from the GIT. So there could be, and the patient is also not likely to be taken orally, especially in trauma patients. So there is the mucosal cells, their growth depends on the stimulus from the oral intake. So usually there could be mucosal atrophy, and also the blood that is shunted from the GIT will also lead to decreased proliferation of the regeneration of the gastrointestinal cells. So this together with the decreased oral intake, and also because patient is not taking enough, so there's also a decrease in glutamine, which is one of the amino acid that is needed for mucosal growth. So in this, look at this, there will be translocation of gut organisms into the portal circulation, and that could be responsible for sepsis and the rest. So for patients with trauma, usually an important clinical perspective there is to commence them on oral feeding, preferably that's the enteral feeding within 24 to 48 hours, even if you want to use NG tube or so. If you provide parenteral, you may replace the amino acids that are lost, but also the stimulus from the GIT will be lacking. That's one point I want to, and then the protein loss is very significant because the little that is generated is converted to the production of those acute phase proteins, and it's been shown that the patient usually the normal daily intake is around 80 to 120 grams of proteins, which you can look at it as 1 to 2 grams per kg per day of protein, and it's been shown that usually during major trauma, a patient can lose up to about 20 grams of urea nitrogen in urine every day. And if you convert that, it amounts to, because 1 gram of urea nitrogen is about 6.25 grams. So if you convert that, it means that the patient is wasting about 125 grams of amino acids per day. And if you want to generate 125 milligrams of amino acid per day, it will amount to like, because 5 grams of that is what you get from 1 gram of amino acid derived from 5 grams of muscle mass. So when you multiply that, it means that the patient is losing up to 625 grams of the muscle mass, which is very significant. And if that is not taken care of, that's to emphasize the relevance of feeding in this patient, because when you break down this protein, the patient will go into immunosuppression, and it's one of the major causes of immunosuppression, and patient not be able to mount any response. And again, another cause of the immunosuppression is the hyperglycemia. How do you manage it? Because for patients that are in this phase of the response, we treat them as critical ill patients following head injury, burns, sepsis, or even immediate post-op following major surgeries. We treat them as critical. And this hyperglycemia is a serious thing, because there is the hormones that are secreted, the catecholamines, they cause some sort of insulin resistance. So this insulin resistance on its own, it will cause a glycemic state, which will also predispose the patient to infection. So you want to also look at insulin. Many people have said that the blood glucose level should not be more than 10 millimoles per liter, but you can titrate that on sliding scale insulin, but you may need more insulin depending on, because of the relative resistance there. So it's also important that you manage the blood glucose of this patient closely.
Thank you very much, Dr. Deshi, for wonderful
and I think again is among all the precipitating factors, the most potent is usually hypovolemia, and it's important to stress that when you sometimes you give those fluid as a routine, but these are the reasons, because you want to prevent this response, because once they are activated, there's nothing much you can do. So you try to prevent them. So that's why you give analgesia and those pain medications. So it's just contributions I have. I don't have questions. Thank you
very much.
Okay, thank you very much for your contribution. Thank you.
Thank you. So any other comments, questions, contribution? And let's limit the comments to within a minute. So because of time. Okay, if you have any question or comments, please, you can use.
Thank you so much.
Yourself.
Hello. Hello, sir.
Hello, please introduce yourself. And
okay, thank you so much. I'm Dr. Ezi. Thank you so much, Prof. Thank you, my consultant and my colleagues. Thank you for this presentation, Dr. Abiliku. It's a well-detailed presentation, and I think anybody that listening to your presentation will really understand what the metabolic response to trauma is, and it's actually what the body does to restore itself back to original status, because That's what we talk about homeostasis, to bring the body back to its original condition. And this is what happens when there is trauma or surgery or burns, infections, and all those conditions that you already mentioned. And like you said, the phases, the ebb and the flow phase. To understand what happens, usually in the flow phase, the catabolic, the anabolic, and then what happens. Like Dr. Davy said, there is insulin resistance. But this insulin resistance is transient insulin resistance. For otherwise stable patients, it is not supposed to cause any harm, of course, but those who are with comorbidities and diabetes and the like, it may also cause damage. But the body tries as much as possible to handle these issues, but also, like you mentioned, there are ways we can attenuate them and help the body recover faster. And that is where also the concept of ERAS comes in, enhanced response after surgery. And this is also what we have to look at. How do we help our patients pre-op, intra-op, and post-op to ensure that they come out better and safer than otherwise if all those measures are not taken. So I think it's a good presentation, and going through it, everybody will understand this and then can present it. Thank you so much for the presentation.
Okay, thank you, sir, for your contribution. Thank you.
Hello, sir. Hello.
Okay, yes, we can hear you.
Okay, thank you very much for the presentation. Thank you, Prof. Thank you, Dr. Goshiriano, for this presentation. Mine is just a comment to Sakinat. Maybe during the introductory part, I felt like you should have made like a separate slide where you highlight like the aim or the metabolic response to trauma. Even though you mentioned it throughout the presentation, but having like a separate slide where you just highlight the aims of the response is to conserve energy and to prepare the body for the subsequent stages of the response. And then when you're discussing the factors that determine the response, even though you highlighted them, but maybe breaking them down into patient factor, trauma factor, and other factors would have been better, so that you can mention a lot of other factors under those ones. So that's just my own contribution, as the other people have already mentioned others. Thank you very much.
Thank you, sir, for the contribution. Thank you.
Thank you, Dr. Abdulkadir. So any other comments? Questions? Okay, if there is no any other comments, we'll call upon Prof to make his own comments on the presentation. Thank you very much, sir.
Thank you very much, Rash.
Thank you, sir.
Right, so this is a postgraduate presentation. I think I'd like to agree with you that Sakina has done very well. There are a few things I'd like to draw attention to about the process before the substance. So fast, within so short a time that you could have actually spent a little bit more time. I don't want to exceed the time you were given, but you move so fast with your slide that following you was potentially challenging. But the message is as if you even set your slides. So if you have so much of stuff, sometimes you try and put fewer points on the slide so that people can see and follow and not write so much. Otherwise, the presentation was good. Second thing is that somebody has just tried to draw your attention again. I think you lined out things very well, but look at the thrust of the presentation. Why is this topic given? And why are we spending so much time? As you correctly said, is how we can prevent or limit this response, the rationale for the response, and what happens when it goes out of order. So it's always important to do this. And I would have loved you to liken it to what the surgical conditions are in which this response goes off key. For example, I wanted to hear you talk about a little bit about what happens in multiple organ failure as part of the bizarre response of the body, so that becomes much more real. Otherwise, looks like you only read it from the books and you are transcribing what is in the book. We would like to hear and see you make a clinical presentation, but you had the points there. So the other comment I would like to make very briefly is your referencing. I think you stayed, the books you consulted are very good. I have no problem about them. But for a presentation of this nature, don't go only to textbooks. And then I think also that you should have looked at Water and Israel. I don't know if you read the book Water and Israel. One of the best write-up of metabolic response to injury is described in Water and Israel. So despite what you have shown us here, I think you should look at Water and Israel, and it will also help you to understand it even much, much better too. You had a lot of information, very much. I think you cover the whole spectrum of both the metabolic response and the neuroendocrine response, which is good. But look at what is in Water and Israel, and it will also help you a little bit more. Now, my last comment is about those mitigating factors to metabolic response. Somebody wanted you to try and link this to ERAS, protocol, which is actually was designed to help stop this. So when you are making a presentation of this nature, it's also very good if you can read a bit widely and look at what clinical surgery is saying so that you can incorporate your answer. The issue of metabolic response, for those who did primaries in those days, it was a typical question in the primaries, but it's relevant throughout clinical practice, not just for the purpose of exam. But I would like to say that on the whole, she has done very well. She was able to express herself very well, and the information came out very, very nicely too. So, but I think for a postgraduate presentation, like I said, widen your horizon a bit and look at other, make sure you make more references than just the books that you quoted. Let me also say that I think the moderation has been very good too. The moderator also was able to follow her closely, and it's very obvious he supervised this presentation, which is exactly what we like to see. So I'd like to thank you for asking me to make this comment. It's a typical question in the exam. You will see this in not just membership MCQs and fellowship MCQs. It's part of what we bring in the oral exam for fellowship as well. So I think it's one of the most important chapters on principles of surgery. And every one of us who is on this forum should know everything about metabolic response And the best way to know it is to apply it on a daily basis to your practice, pre-operatively, intraoperatively, and post-operatively. Thank you very much.
Thank you very much, Prof, for your wonderful guidance, comments, and God's willing, we are going to take note of all the inputs, and she will effect those inputs in her slides before submitting to the departmental library. Thank you very much, Prof, for the guidance and comments. We really appreciate your inspiring effort to towards the development of medical education in the country and also beyond. Thank you very much. Thank you, sir.
Thanks.
So thank you all for participating in this first lecture. Next week, we'll be having alternatives to blood transfusion. And it will be moderated by Dr. Obo. Felix is also one of our consultants here in Federal Medical Center. So I encourage all of us to go through Prof's advice on this topic, as well as reading in preparation for the next topic, so that we'll have meaningful contributions and questions. And also the presentations are also recorded. We can use them as our reference material for revision, as well as when the edited slide is available, it's going to be shared on the platform. Thank you very much all. In the absence of any other questions, we are going to end the meeting now.
Can I greet Dr. Dades?
Prof, good evening, sir.
I saw. Good evening.
Good evening, Prof. Thank you, sir.
All right, God bless you.
Glad to hear from you again, sir. Thank you, sir.
Okay.
Thank you.
Thank you very much all. Next week, the link will be shared before time. Thank you.
Somebody is asking me about the water in Israel. That means there's a whole generational change. It's a textbook of general pathology, water in Israel.
Yes. That means they're not, sir.
Yes. Nice.
All right. Thank you, sir. Good night, Prof.
Good night. Good night, everyone. Thank you, sir.
Good night.
Bye.
Bye.